Hi guys, and welcome to probably the most in-depth lecture you will have from me. This is in regards to your chapter 15 with schizophrenia spectrum and other psychotic disorders. There's lots of new words and new concepts for you, so it's, like I said, going to be a little bit more in-depth than some of our other lectures there. So let me start with a vignette, a little clinical picture of a man named Miles. He's 20 years old, and he was brought to the emergency room by the campus police at the college in which he was attending, but he had been suspended several months ago. A professor had called and reported that Miles had walked into his classroom, accused him of taking his tuition money, and then he refused to leave. Although Miles had much academic success as a teenager, his behavior had become increasingly odd during the past year. He had lost many friends and did not seem to care about his academic or social pursuits. He began wearing the same clothes every day and he seldom bathed. He lived with several family members but rarely spoke to any of them. When he did talk to them, he talked about how he had found clues that his college was just a front for an organized crime operation. He had been suspended from the college due to missing many classes. His sister said that he had often seen him mumbling quietly to himself, and at times he seemed to be talking to other people who were not there. He would emerge from his room and ask his family to be quiet, even when they were not making any noise. Miles talked about the organized crime so much that he was prompted again, or his family was prompted again to take him back to the emergency room. On exam there, Miles was found to be a poorly groomed man who seemed inattentive and preoccupied. His family said that they had never known him to use drugs or alcohol, and his drug screen results were negative. He did not want to eat the food offered by hospital staff, and he voiced concerns that they may be putting drugs into his food. His father told hospital staff that Miles' grandmother had a serious illness and had spent 30 years in the state hospital, which he believed was a mental hospital. Miles' mother left the family when Miles was very young. Miles agreed to sign himself into a psychiatric unit for treatment. His story reflects a common case in which a high-functioning adult goes through a major decline in day-to-day skills. There's a lot of disorganization, as you can see here. So the illness of schizophrenia can be treated, and a good outcome is possible. Having said that, it cannot be cured. In the case of Miles, he was having persecutory delusions, auditory hallucinations, and negative symptoms that lasted for at least 1 year. So let's go into the history and facts of schizophrenia. It can be seen dating all the way back to 1550 BC in the Ebers Papyrus, that very famous papyrus that was found in Egypt, and it was thought to have stemmed from divine punishment. So because a person committed some great sin, they were ultimately tortured with a mental illness. Now, in the late 1800s, where psychoanalytics and psychiatry was just kind of really exploding, that's where Sigmund Freud came about, there was an exploration of biology versus genetics. And there was a differentiation of schizophrenia from other psychoses, and that was known as dementia praecox. Having said that, dementia praecox didn't have all of the symptoms of schizophrenia, so this guy named Eugene Bleuler gets all the fame for really honing in on both the positive and the negative symptoms that are associated with schizophrenia. Having said that, he really kind of named it a little dumb. In Greek, schizo means split and phren means mind. So when we say schizophrenia, we're literally meaning split mind, and that may make us believe that they have some kind of other like dissociative disorder that will go into the future. But here, we'll give all the credit here to Eugene Bleuler. Here's some more facts about schizophrenia. So 95% of violent criminals do not have a mental illness. I just want to kind of reiterate this, that there's been lots of studies out there that our schizophrenic patients are way more likely to be victims of crime than they are to be violent criminals themselves. Makes up a very small percent of the population, so about 0.5% of the general population has schizophrenia. Having said that, 1 in 5 homeless people have schizophrenia, so this is just another evidence of this decline that can happen in a person with schizophrenia. Schizophrenic patients have some evidentiary loss of dendrites in their brain and will lose about 2% of their brain mass every year for the first 5 years of the course of the illness. So there is some quantitative evidence of our schizophrenia there. First psychotic episodes can be linked to cannabis use. So they have dotted a map of the entire world, and they have found that people who live in a population where marijuana is legal have more incidences of psychoses and initial psychoses with a subsequent diagnosis of schizophrenia. So kind of interesting stuff. About 90% of people with the illness will smoke cigarettes. I get lots of stories from the students who go to PACT, and that's where they're kind of meeting the patients at their place of residence, whether it be a street corner or a tent or a hotel or wherever they may live, and the nurses will build a rapport with the patients and bring them cigarettes. So it's part of the establishment and continuation of that good rapport. So about 10.1% of all suicides the patient had or the person had schizophrenia. So while there might not be a lot of violent crimes against others, there is most certainly some violent crimes against themselves, some violence toward themselves there. The etiology is very complex and not completely understood, although the most popular hypothesis is called the dopamine hypothesis, and this is really evident when we go into our antipsychotic medications because they do work on the dopamine level. So one thing that we do know is that dorsolateral prefrontal cortex gets thinned out due to the loss of dendrites. That's the evidence there. So let's talk a little bit about the dopamine hypothesis. Dopamine is unique in that it's readily available in the brain. It works in 4 known and specific pathways, which explains speculation for being involved with schizophrenia. So dopamine will cause hyperactivity of the mesolimbic pathway, and in this way, I don't expect you guys to know this or know this any more than just what this slide says. That'll explain delusions and hallucinations. It'll cause a hypoactivity of the mesocortical pathway, which explains the patient's negative symptoms. We'll go into positive and negative here in a moment. And then it affects the nigrostriatal pathway, which controls motor function. And when it has some interferences, like such as in the case of schizophrenia, the patient will have either decreased or increased dopamine levels, and the decreased dopamine will lead to dystonia or a lack of motor function and Parkinson-like symptoms. We'll go over those in just a minute. And then increased dopamine will lead to hyperkinetic movements like tics and dyskinesias, which are involuntary movements. And then another pathway that is affected by schizophrenia is the tuberoinfundibular pathway, which interferes with prolactin release. Prolactin is an interesting hormone, and there's actually a lot of conditions and drugs that can make a person have a prolactin release, and when that happens, the patient might actually lactate from their breasts. That can happen with some of our medications like Reglan and Phenergan. They're known to do that. Reglan especially, long-time Reglan use might cause a person to lactate. Interesting side note there. So the DSM-5 criteria, this is what the tool that we have to diagnose somebody. The patient has to have the following of these symptoms. So for at least 1 month or longer within a 6-month time period. And at least one of them must be numbers 1, 2, or 3. The patient will have delusions for at least 1 month in a 6-month period, and or hallucinations and or disorganized speech. They might also have grossly disorganized or catatonic behavior. Catatonia happens when a patient is just kind of mind absent. There won't be any movement, or if there is, it'll be very, very slow. It's also, the patient will have negative symptoms such as a diminished emotional expression. They'll have impairment of one of the major areas of functioning for a significant period of time since the onset of disturbance. So this is one of those things, like I said, and the patient has to have impairment in functioning. So they'll have impairment of work, interpersonal relations, or self-care. And that happened in Miles's case, right? They'll have some of the 6 disorders that must last for a continuous period of at least 6 months. This 6 month period must include at least 1 month of symptoms or less if treated that meet criteria A, which are those active phase symptoms. So if you go back here, that's either the delusions, the hallucinations, or the disorganized speech. Schizoaffective disorder and bipolar or depressive disorder with psychotic features have to be ruled out. No major depressive or manic episodes occurred concurrently with active phase symptoms, and if mood episodes like depressive or manic episodes have occurred during the active phase, they have been present for a minority of the total duration of the active and residual phase of the illness. And bipolar, as we will find out, can have quite an active phase of mania, which leads to psychosis. So we do have to rule out that this person is not bipolar. So if there's a history of autism spectrum disorder or communication disorder that happened at child onset, the diagnosis of schizophrenia is only made if prominent delusions or hallucinations along with other symptoms are present for at least 1 month. So if we go back here, they can't have that disorganized speech because a person with autism may already have disorganized speech there. So phases of schizophrenia, the patient will go through a premorbid phase. This occurs prior to clear evidence of symptoms. So they might have, what we call like a personality trait, like that person's shy or withdrawn, or they're just not that great in school, or they're displaying antisocial behavior. And antisocial behavior in this case, or in the case of mental health, means that they're doing things that have gone against society, not just that they're withdrawn. So that means they're acting out and being I don't know what I want to call it, being a beast in society there. That's the best thing I could come up with. Come on, Karina. Now we have our prodromal, which is a more clear manifestation of symptoms, and the average length is thought to be 2 to 5 years. Now here the patient will have social withdrawal, and in many cases, if we are diagnosing this person at age 20, then these symptoms might have been going on at like age 14, where a child will have more OCD-like behavior, that kind of component where they're obsessed and then have a compulsion there. And then this active psychotic phase will occur. And this is just as the name suggests, the person will go into psychosis. This is where our positive symptoms are prevalent, and we'll go into those positive symptoms, I swear. But once again, if we go back to that DSM criteria, they're going to be like our delusions, our hallucinations, and our disorganized speech there. And then a patient will go into this latency phase or residual, where they will no longer have these positive symptoms, but they will have these negative symptoms, which are just as important for the diagnosis as the positive symptoms. So we talked about psychosis. What exactly is that? Psychosis is a symptom, so we have to exclude some things that can also cause psychosis, such as substances or medications. Cocaine and methamphetamine are very popular for causing psychotic symptoms, and also marijuana, like we had talked about, and synthetic marijuana or spice. That's really been known to cause these psychotic symptoms, or other medical conditions that is seen on your table on 15-2. And another cause might be schizophreniform disorder. And schizophreniform disorder is what we can call schizophrenia before we can name it schizophrenia. So it's all the symptoms of schizophrenia, but the symptoms only last 1 to 6 months in duration, and then we're gone. After 6 months, we can officially title it schizophrenia. The book, I don't know why they do this, but they go over some subtypes of schizophrenia, and they are not included in the DSM criteria, and we don't use these anymore, so I just want to kind of let you know that they exist, but they're in people's lexicons there, but it's no longer things that we use. So those subtypes used to be paranoid schizophrenic, catatonic schizophrenic, and schizoaffective. We do a lot of they used to do this. So schizophreniform disorder, just like I said, those schizophrenia symptoms, but they only last for up to 6 months, no longer than. And schizoaffective disorder, you won't go too much into this, but it's basically experiencing a combination of both mood and organizational disorders. So you will see schizoaffective disorder quite a bit at Lourdes Counseling Center, because the symptoms can lead to involuntary admissions and commitments that when they add the mood on there, a patient can become more violent and unpredictable. So let's talk about these positive symptoms here. And we'll go down with the mental status exam and talk about the patient's thought content and their thought form. So in content, they will have delusions, which we'll go over on the next slide. And they might kind of perseverate on some religiosity. So kind of interesting thing if you think about how this works. Our prefrontal cortex, as you well know, is that kind of social part of our brain, the part of our brain that lets us fit into social situations. And like we had talked about, the larger your prefrontal cortex, or the larger the social status there, the larger the prefrontal cortex in all mammals. So patients will oftentimes, because they don't have control over this prefrontal cortex, we'll talk about all the taboos that we're not supposed to talk about. So we don't talk about religion or sex or politics, to have like a a decent conversation with a person. But oftentimes you will see patients kind of really toning in on these three topics there. And then they might have paranoia, which is extreme suspiciousness. They might have magical thinking. It snowed last night because I wish it would type thinking. And then as far as the thought form, they will have or may have some associative looseness or looseness of association there, where you will be talking to them about a boxer and they'll go kind of back and forth between boxer the dog or boxer the fighter, and what they're saying kind of makes sense when you're talking about each, but not really both. Then we have our neologisms there, which is making up a new word, which I think I might have just. Mary Poppins, with her supercalifragilisticexpialidocious, has made up a new word, and so might your patient. Then they will have or may have concrete thinking, which is the opposite of abstract thinking, or the way that we as nursing students and nurses are able to think about the world in an abstract manner. So when they hear something about loose lips sink ships or many other proverbs, they will not really understand the association. They're themselves thinking of how can a lip that is loose sink a ship, when we all know this to be part of the World War I propaganda there, where they were encouraging sailors and soldiers not to write too much about what was going on back to home, for fear that the mail might get intercepted by the enemy and their plots might be found out there. So then we have the potential for a cling thought form, and cling is oftentimes the forming rhyming words associated with the word that was just said. So clang, bang, sang, dang. And then just along with this associative looseness, I'm trying to make sense out of sense type thing. Word salad are actual real words, but there's no association with them. So if we're talking about college, water ball, dog, ping pong, it's just words that don't make sense together. And circumferentiality is where you ask a question and the patient will come back around to the answering that question, but it happens eventually, and we'll take you around the circle and come back to it. Then they will or may have tangentiality, which means they went off on a tangent and they did not come back around to answering the question. And then mutism is not saying anything. And they might have perseveration as far as their thought form, where they kind of get stuck on a thought idea and don't relieve themselves of that thought. So here's our delusions. This, once again, is a positive symptom. A delusion is a false personal belief that is not consistent with a person's intelligence or cultural background. The individual continues to have the belief in spite of obvious proof that it is false. And this can't be explained by culture. So if we use religion there, some cultures believe in like objects as gods and things like that, which makes total sense to them, but that may not make sense to somebody that's not in that culture. So it can't be explained by their culture. So they may have an idea of reference. They're making things that aren't important. That's what ideas of reference mean. So if you say, oh, look at that waitress, every time she sets the table, she is moving that fork a certain direction. Just look at that. May not mean anything, right? And here's something I would like to warn you about, that the more intelligent that the person is, the more believable the delusion may seem, and it actually might prevent them from getting quick care there. A patient may have a erotomatic or manic delusion, which it is where the individual believes that someone is in love with him or her, and this is typically a famous person. So Taylor Swift is in love with me. Grandiose delusions, which are these irrational ideas regarding their own worth, talent, or knowledge, or power, and it usually involves big characters here. So the patient is involved with the CIA, and Donald Trump himself is giving him calls and telling him what to do next and things like that. Big grandiose delusion. Jealousy delusion, something like you're cheating on me, I just know it. Persecutory. This is one word I could not say. This is the most common, actually, and this is where an individual believes that they're being persecuted or malevolently treated in some way. And so then we have our thought withdrawal, where a person thinks that their thoughts are being removed by another person. And thought broadcasting, where they have the belief that other people are able to relieve or read their thoughts, like a radio signal or something like that. Somatic, where a person will believe they have some medical issue. An extreme case of this is a medical student who had schizophrenia. Now just think about this. This is like right at the same time where people are establishing careers and being students and stuff like that. This is where those positive symptoms will generally start. So now we have this medical is student who had these delusions that he believed that these like other hallucinations and things like that were caused because of his adrenal glands. So he was going to perform some self-surgery at home to try to get rid of his adrenal glands, and in the process he severs some important arteries and comes to the hospital, with this trying to get rid of the adrenal glands on the kidneys, and he's a big huge bloody mess and is considered a trauma at that point, right? And he's just asking for help with a little bit of cauterization because he is so sure that these adrenal glands are what is causing these hallucinations for him. So that's a really sad case. And then the person might have mixed delusions and there's no particular theme there. Kind of all over the place. Hallucinations are this false sensory perception that's not associated with anything that's real that's going on, and they may involve any of the five senses. Auditory hallucinations are the most common, and these are the most likely to cause like a command hallucination is what they call it, where the auditory stimulus that they're getting is commanding the person to do something that they normally wouldn't do. So as far as the negative symptoms go, remember we have this period of psychosis with all these positive symptoms, and this is what usually brings them into a place like Lourdes Counseling Center. And then we get medications under control, and oftentimes patients will slip really far deep into these negative symptoms because we're really just titrating the medications at that point. And it's really easy to see that these patients at the counseling center will have some of these negative symptoms, so I'm sure you guys will be able to see at least some of those. So the negative symptoms get worse as the disease progresses, so medications do help with this. So where a patient might have really pronounced negative symptoms when they were in their 40s prior to the age of psychopharmacology. Now we're seeing that in their late 70s and 80s. So it's buying them some time, these medications. Kind of interesting. So a patient will have an affect that is described as inappropriate, like they're flat or apathetic. Volition is this inability to initiate a goal-directed activity. So they're just kind of stuck spinning. They don't have any goals, and they won't do anything to create an activity that would inspire a goal. They will have impaired social interactions as well as social isolation. Lack of insight, or anosognosia, is the same thing as lack of insight. This is where they're you ask them about their diagnoses and they won't have any insight into that diagnosis. They'll have lack of energy or anergia. Oh, excuse me. And they might have something called waxy flexibility. So there's this YouTube video that's out, and I'll make sure to put in a link for you that shows waxy flexibility. Really, really good. And this is back in the 1930s, so these are actual patients. They just put like a blindfold on them. This is before HIPAA. We can't do that anymore, guys. So we'll just show this person that moves the patient. They'll move their arm, they'll put them in all sorts of interesting kind of formations, and the patient will just stay there. Or they might have posturing, which is like these bizarre postures there. Some may stand at like attention and try to do a yoga pose for as long as they can, just very slow and almost just sometimes just absolutely no movement there. And the patient might be found pacing or rocking. These are negative symptoms. A patient will have a loss of pleasure or anhedonia. We get our word hedonistic from this lady over here. She was a Greek goddess found in the picture, and her name was Hedonia, and she was the goddess of all things pleasurable, or the pursuit of pleasure there. So really, anhedonia is the lack of pursuit of pleasure. And then you might see the patient have some regression, like you might see some defense mechanisms occurring because of this. So treatment for these individuals in the medical community, obviously we're going to be doing our milieu therapy, and the nurse is going to be taking care of everything safety-wise, but we can do medications for this patient, and then lots of different therapies, individual, group, behavioral therapy, and social skills training, and then the PACT team, which is this really great team that goes out in the area, like we had talked about, where the patient lives, and they do some aggressive treatment for these patients to meet them before they have a psychotic event that might take them to the hospital. We also go big into these antipsychotic medication. It doesn't treat schizophrenia, but it will treat the positive symptoms, the psychosis, right? The positive symptoms. And these include our first generation, which is chlorpromazine and haloperidol or Haldol, and this works on the D2 receptors. We have dopamine receptors 1 through 5, and this one hits number 2. And it decreases positive symptoms, but also increases negative symptoms, which may lead to a decreased level of alertness. And oftentimes we will use like a Haldol in the emergency department. Not our favorite drug, but we still use it sometimes. It can cause a QT prolongation, which is why they use IM injections instead of IVs now. Back in the day, we used to use IV Haldol quite a bit, but you don't want a patient to go into a torsades de point. Christina will tell you all about why that isn't a good thing. Our second generation antipsychotics, or also known as our atypical antipsychotics, are clonazepine, olanzapine, risperidone or Risperdal, and aripiprazole. And we like to use aripiprazole, quite a bit in the psych situation there. It's really great because it's got this sustained release injection. So you can give a patient an injection once every 30 days, which is really nice. So if you're working in PACT, you may be distributing these antipsychotic medications. As we can recall, there's lots of homelessness that's involved with this, social disparities, so people don't have the organization to have transportation arranged for these appointments sometimes. So meeting the patient where they are and reducing that chance of a psychotic or positive symptom event is really going to work well for them. And these second generation or atypical antipsychotics, they work on both the D2 and the serotonin receptors. They can cause weight gain, sedation, orthostatic hypotension, and extrapyramidal side effects, which we'll go into on the next slide, and also have a chance of causing agranulocytosis, or where we're not producing those white blood cells. So these patients will also get blood checks at the same time to make sure their white count is looking good. So here's our extrapyramidal side effects. A patient can have dystonia, which is this muscle stiffness, body spasm, eye deviation type thing. They can also get dystonia from Reglan or promethazine. So I think I'm at 3 people who have had dystonia after I've given them like a Reglan in the emergency department or on the surgical floor, actually. And this is treated with an anticholinergic benztropine, and it's an IM injection. Then we have akathisia, or restlessness, leg movement, pacing. They're getting all wound up and anxious there. And this is treated with benzodiazepine, like our good old-fashioned IV Benadryl. Parkinsonism, the patient will have Parkinson-like features where they'll have the shuffled gait, masked face, which means kind of like this no expression face, drooling, tremor, and rigidity there. And this is treated with diphenhydramine or benztropine, once again anticholinergic. And even though this is being treated, the symptoms can go on for months, so people can be getting like a scheduled dose of these medications, benztropine or diphenhydramine, or kind of a PRN basis where they can give them those when the symptoms really start acting up a little bit more. So tardive dyskinesia is an involuntary movement of oral facial muscles. So you'll see the patient do this kind of tongue protrusion thing and lip puckering, chewing, or grimacing. And the only treatment for this is withdrawal of medication. And unfortunately, it can take some time to have an alleviation of those symptoms. So I want to talk to you about nursing care while we are together, and this is it. That's it, guys. We got through it.